Hi everyone, welcome to this another session of the MCQ discussion. We enter the month of thorax and here let's start this question over here. 60-year-old man presents to the clinic complaining of persistent cough for the last few months, associated with a progressive shortness of breath. During the past year, he has also noticed some weight loss and decrease in his appetite. Chest X-ray shows a mass in the right lung. CT demonstrates a 5 cm mass with irregular borders near the hilum. CT guided biopsy is planned during the procedure just after insertion of the needle. The patient starts to feel the pain in his right shoulder. Which of the following nerves is responsible for this shoulder pain? So now anatomically they are saying that the site is where? Near the hilum. CT guided biopsy, no matter you introduce the ultrasound, CT, whatever, but needle has to go. The moment the needle was inserted, the patient started to feel the pain in the right shoulder. Where was the needle inserted? Around the hilum. Pain going to the shoulder. Remember, we did an MCQ already. Nerve passing through the middle mediastinum, supplying the pericardium, having a case of pericarditis, if you remember yesterday. Pain was in that case also going to the left shoulder. What is the nerve? Nerve was the phrenic nerve. I hope the same answer goes over here as well. Why? Because root value of phrenic nerve remains C3, C4, C5. That is the dermatome of the shoulder and location also. Therefore, answer will be perfectly phrenic nerve over here. Here you can see in images, these are the sort of side types of pleura shown over here. And do remember that the pleura sensation and the nerves are also written over here. So you see the nerves, the phrenic nerve, you can see it's a referred pain going to the shoulders. That's very important. Okay. Therefore, answer for this question B will be phrenic nerve without a doubt. Other options like intercostal nerve, we all know it's a thoracic spinal nerve. Vagus nerve is the 10th cranial nerve. Pulmonary plexus or the autonomic plexus supplying the lungs. The thoracic spinal nerve is same as the intercostal nerve. Let's see the next one. As a surgeon exploring the thorax, you will be able to identify the right pulmonary artery. So there is a pulmonary trunk dividing into two pulmonary arteries. So identify the right pulmonary artery in which of the following location? Anatomically, where would you see the right pulmonary artery? Think. The moment a question like this comes in your mind, the diagrams. Therefore, anatomy, you always keep on saying diagrams are so important. The diagram should run in your mind. Okay, the diagram should run into your mind. Like this, the heart. Okay, fine. Then here is the right ventricle. Here is the left ventricle. Okay. From the left ventricle, we had this aorta and arch of aorta, right? From the right ventricle, we had this pulmonary trunk coming out, right? Divided into left and the right pulmonary artery. In the question, what they are asking is the right pulmonary artery. So here they are asking about the right pulmonary artery, this one. Okay, so they are asking of this artery. Now, what happens after this? After this, can you see the right pulmonary artery? No, why? Because it is going behind the arch of aorta. Then what actually happens over here as well? Here, this is which vessel coming down? This is the superior vena cava. Coming down where? Coming down to enter into the right atrium. So what is this? Superior vena cava. Do you see the right pulmonary artery in front of superior vena cava? Think. Do you see the right pulmonary artery? No, we don't see the right pulmonary artery over here. Right pulmonary artery goes behind the SVC, then it enters where? Into the hilum of the right lung. So this you should know this, right? What will be the answer? Anterior to ascending aorta, obviously not. Posterior to ascending aorta and anterior to SVC, no. Posterior descending aorta will be lying more posteriorly into the posterior mediastinum, so that is not a point over here. Option D should be the answer because that is the only option left. Posterior to ascending aorta and SVC. Yes, this would be our answer. Hey, basic question. Here we have a couple of images. This is what I was trying to make, but you can very well see that this is a pulmonary trunk over here and this over here is a right pulmonary artery. It is being hidden by what? By this aorta and the SVC. If you see the posterior view of the heart, then you will realize that this is over here. This is the right pulmonary artery over here. This is the right pulmonary artery. This is a posterior view. You can see it is going behind the ascending aorta and behind the SVC. This is a posterior view. Remember, why posterior view? You can see the pulmonary veins. You can see the left atrium over here and all that. Next question. An infant is born with an abnormally thin wall in the smooth part of the right atrium. So right atrium has an anterior wall which is rough, pectinate muscles. And the posterior smooth wall where basically the SVC and the IVC enter. So vena cava enter. So infant is born with an abnormally thin wall. Might have been diagnosed in an echo. This condition may be related to underdevelopment of which of the following embryonic structures. So embryologically they are asking that the thin wall of the right atrium is formed from which part. So as we already discussed, see, in the right atrium that thin wall will actually be a part because the SVC and the IVC are entering. As you will see in the embryology of the heart, that when these veins are entering into the development of the heart, they are known as what? Sinus venosus, right? And sinus venosus divides into two horns, the right and the left horn. Now it is the right horn of sinus venosus that forms the sinus venerum. That forms the sinus venerum over here. That is actually forming the smooth part of the right atrium. If you start searching the options, obviously you can already see the sinus venosus as being the answer over here. How to easily rule out other options is also not very difficult. The pulmonary trunk is a pulmonary trunk. It is coming out of the right ventricle. Why would it form any part of the right atrium? Apply common sense. Conus cordis is actually more distal. It is forming the outflow part of the right and the left ventricle both. Truncus arterius is forming the pulmonary trunk and the aorta. Obviously, answer becomes sinus venosus. Let me show an image over here. This image is very, very important, right? This is from the venous end, and the upper part, this is the arterial end. And here I start to highlight, this is the sinus venosus over here. You can see the right horn of sinus venosus is absorbed into the right atrium, forming its right smooth part. So here you can see both the horns and how it is entering into the atrium. Then from atrium to ventricle, then you have the conus cordis, then you have the whole truncus arteriosus. So they are forming the different, the distal part of the circulation of the heart. So remember that. Okay, next question, a very interesting question. Listen carefully. I'll read it out. 47-year-old is brought to the emergency 30 minutes after he was involved in a motor vehicle collision. After half an hour. On arrival, he is unconscious and unresponsive to painful stimuli. Okay. So on arrival, he is unconscious and unresponsive to the painful stimuli. His pulse is 120, respirations are fine 10, and BP is 88/60, slightly going down. Obviously, going to hypertension, so infusion of NS is begun and intubation is attempted without success. Intubation they tried, but without success. Why intubation? Because the respiration is also going down. And he is unresponsive and unconscious. The pulse oximetry on 20 liter per minute oxygen via bag and mask shows a saturation of 78%. So you need intubation, right? But that is not happening. He is also unconscious, so it's called emergency, obviously. Now, the most appropriate next step in the management involves passing a tube through an incision which of the following structure. Now, they are not asking the medicine question over here, or the surgery question, or the anesthesia, or the emergency medicine. They are saying, okay, BP is going down, patient is unconscious, pulse oximeter, saturation is going down, we have to oxygenate the patient. Intubation is not having success, the laryngoscopy and all that might not have worked. Now, surgically, you need to do some procedure. Now, to cut which structure you have to cut, what you have to see, we have to enter into the respiratory passage. That is, you have to enter into the trachea or the bronchus, obviously into trachea. Via larynx, you are not able to enter, or via the mouth, you are not able to enter. So, you have to do a incision over here. What you can do is, you can do a needle cricothyrotomy or a surgical incision cricothyrotomy. So, basically, to start with, you have to do a cricothyrotomy. What is cricothyrotomy? You have the laryngeal cartilages, the thyroid and the cricoid. The vocal cords are basically behind the thyroid. So, you have to cut, or you have to enter below the thyroid cartilage. That is known as cricothyrotomy. Below thyroid, you have the cricoid. Between thyroid and cricoid, you have a cricothyroid membrane. You have to enter through that. So, there you have to cut, obviously, some structures. What structure you have to cut? That is the question. Now, options are buccopharyngeal fascia. Now, see, buccopharyngeal fascia is actually in the posterior part of pharynx. Rule this out. Second option is investing layer of deep cervical fascia. Now, investing layer of deep cervical fascia, if you go through this topic, a very important topic, you will see that it encircles the neck like a collar, and therefore you have to cut this. You have to cut this no matter what. So, if you have to enter the cricothyrotomy, the structures that you need to cut are obviously the skin and the superficial fascia. Then you have to cut the investing layer without a doubt to enter where? Into the pretracheal fascia. Then you have to enter through the pretracheal fascia, and then slowly will reach the membrane, and you have to enter through the cricothyroid membrane into the respiratory passage. But you have to cut investing layer. So, investing layer need to be cut. Other options, let us see. Prevertebral layer. Now, prevertebral layer is anterior to the vertebrae, that is more posterior, more deep, that will not be encountered. Cricotracheal ligament in not. Answer over here, investing layer. Let me show you an image over here. This is what is being done here. You can see the thyroid cartilage over here. This is thyroid cartilage, and there's some cricothyrotomy being shown over here. Okay, so do remember this. Here are all the layers of the cervical fascia. I'm just going to highlight this, and I'm going to tell you the different sort of fascias. If you go from most superficial part, okay, then you have this pretracheal fascia. Okay, you have the pretracheal fascia. Pretracheal fascia, you can see it is encircling the thyroid gland over here in front of the trachea. Then you have, this is the investing layer of deep cervical fascia. It actually splits to enclose the muscles like sternocleidomastoid and the trapezius. Behind you have the prevertebral fascia. Where is the prevertebral fascia? Let me put an arrow over here, better than searching. This is the prevertebral fascia. This is the prevertebral fascia. This all is prevertebral fascia. Here you have this. In front, you have this carotid sheath also over here, encircling the carotid vessels. So, investing layer of fascia, it actually is encircling the entire neck. So, you have to cut it. Without cutting, you can't enter. Okay, here's one more question. In a balanced coronary artery pattern, the blood supply to the majority of the interventricular septum is derived from which of the following? So, what you should know, that we are dealing with the heart over here. This is the right ventricle, that is the left ventricle. Anteriorly, if you look, then you can realize, okay, this is the anterior interventricular septum. But as you trace it posteriorly, it somehow goes like this. So you can yourself imagine that this whole thickness is what? This whole thickness is the interventricular septum. I am sure you can understand this. This whole thickness from anterior to posterior interventricular sulcus, you have the interventricular septum. So this whole is IV septum. What are the different arteries running over here? Anteriorly, we all know this famous artery, that is the LAD. Left anterior descending, also known as anterior interventricular artery. If you trace the right coronary artery from here, it will go behind, and behind it will give over here the artery, because it's a balanced coronary artery pattern. So heart is right dominant heart, meaning by that the RCA is giving off the posterior interventricular artery. So this artery will be posterior interventricular artery. Now you have an LAD over here, which is one of the initial branches of the LCA, which is quite bigger, and you have a PIVA, which is a branch from the RCA, which is not that big. So what actually happens is this LAD will start to give off branches to the interventricular septum. So will the PIVA will also give branches, but you can see the difference. The difference over here is that this LAD branches will supply maximum part of the interventricular septum, and some part of the interventricular septum is also supplied by the PIVA, but maximum part of the LAD. So now they are asking you, the majority of the interventricular septum is supplied by what? It is by the LAD, or anterior interventricular artery. Understand this. This is the balanced coronary pattern having the right dominant heart. When we say dominant heart, it means that the PIVA is coming from the right side. If it is the left dominant, we will say the PIVA is from the LCA. Okay, here also you can see the left coronary artery giving off the LAD, that is supplying the majority of the septum over here, and the RCA giving off the posterior descending artery, that is supplying some part of the interventricular septum. Also do remember that the RCA will also supply the AV nodal branch. Right? So that's all. I hope you're enjoying. We'll meet again tomorrow with some other important MCQs. Thank you. Bye-bye.